Hi everyone, my name is Layla Aitash Kador, and I'm a P4 student at St. Louis College of Pharmacy, and I will be talking about patent ductus arteriosus. So to start, understanding how blood flows and the role of ductus arteriosus is very important for the basis of just understanding what a PDA is and also how it could have some harmful consequences. The ductus arteriosus connects the pulmonary artery to the descending aorta, and that is also it's seen in both pictures. It is more depicted on the right side. However, before birth, the blood does not have to get to the lungs to get oxygenated, as the ductus arteriosus shunts the oxygenated blood from the placenta past the pulmonary vasculature. However, then after birth, the blood then has to receive oxygen in the lungs, and the ductus arteriosus has to close to reach the lungs. And when this closes, it forms this ligamentum arteriosum as seen in the left-hand side. And this closes usually within a few days after birth. Now, what happens if it doesn't close? That is considered patent ductus arteriosus. So some complications of PDA are significant morbidity and disease states with high mortality. When left to right shunting continues, blood can back up into the pulmonary vasculature and can cause pulmonary edema, and there is higher incidence of bronchopulmonary dysplasia, necrotizing enterocolitis, and intraventricular hemorrhage. Also, at the same time that pulmonary edema occurs, systemic blood flow is also compromised and ischemic damage may also occur. The incidence that occurs of PDA increases as gestational age decreases. So it is more seen in preterm babies. It is actually about 54% seen, 54% of infants born between 22 and 26 weeks. It's seen of PDA. So preterm babies more often. This is the biggest risk factor. And then respiratory distress syndrome increases the risk of PDA as well. So with that as well, some other risk factors to consider: excessive fluid administration, birth asphyxia, RDS, congenital syndromes like rubella syndrome, trisomy 13 and 18, and congenital heart disease as well. Congenital syndromes make up about 60 to 70% of those that have PDA. The ductus arteriosus is mostly made of smooth muscle fibers within elastic tissue. This is different than the aorta and the pulmonary artery. They are mostly made of elastic tissue. When thinking about the constriction that occurs of the ductus arteriosus in term babies, as the baby starts breathing, the partial pressure of oxygen increases and prostaglandin and prostacyclin decreases. And this leads to cell death and growth factors, and this therefore forms the ligamentum arteriosum. There is a theory of platelet activation that is also considered, where coagulation factors come into play as well. When thinking about the preterm infants, their tissues are not as sensitive to that change in partial pressure of oxygen, and the prostaglandin and prostacyclins do not decrease as quickly. Also, the placenta removal occurs, which has most of the prostaglandin and prostacyclin production that occurs. And preterm infants as well have low platelets, which goes back to the theory of platelet activation, and therefore that is not seen where the coagulation occurs. So the most difficult question to ask is, when do you treat the PDA? There are 3 different approaches that are studied. Symptomatic approach or rescue approach is the most common approach seen. It is also considered a watch and wait approach. It is the most common approach because it avoids unneeded medications. It waits for clinical signs to occur, clinical signs being rising oxygen requirements, inability to wean, ventilator, bounding pulses, or an active precordium. The pre-symptomatic approach is one that screens all preterm infants with a cardiac ultrasound and then treats those that do have this PDA. The prophylactic approach is one that treats all infants start with indomethacin 24 hours after birth, prophylactically. So when talking about which treatment NSAID therapy is the main topic of discussion, the 2 NSAIDs talked about is indomethacin and ibuprofen lysine, their mechanism of action being inhibition of prostaglandins, specifically via the inhibition of the COX pathways. There is no difference seen between indomethacin and ibuprofen in the successful closure of PDA, and it is seen to close up to 75% of the time. The side effects seen is a decrease in cerebral, GI, and renal blood flow, and this can cause IVH, NEC, and a decrease in urinary output, and increase in BU and creatinine ratio, and even platelet dysfunction, which therefore means that contraindications include infection, bleeding, coagulation defects, NEC, renal impairment, and the congenital heart disease. An important clinical pearl to consider is that there is no reasonable use of these beyond 3 to 4 weeks of age, just because there has been no successful closure of the PDA past this time, and therefore surgery must be considered. An important drug interaction as well to consider is NSAIDs with glucocorticoids, like hydrocortisone specifically, because it can increase the risk of spontaneous intestinal perforations. Although ibuprofen has had some fewer side effects than indomethacin, there has been no long-term studies that have been shown, which is why sometimes indomethacin is preferred. So just looking at the comparison between the 2, indomethacin prevents also the pulmonary hemorrhage and starts with an initial dose of 0.2 milligrams per kilogram, followed by the postnatal age determination then for the following doses, and can be 12 to 24 hour intervals. And for ibuprofen lysine, as I mentioned, there was no long-term data, starts with 10 milligram per kilogram dosage, and then is followed by a 5 milligram per kilogram dose, and is a 24-hour interval. It does have that less frequently reported side effect and has been shown to have some increased bilirubin in vitro, and it is preferred in moderately impaired renal function. There has been a newer option that has been considered, and it is Tylenol. It's the mechanism of action is not fully understood. However, it inhibits prostaglandins, but at the peroxidase site instead of it inhibits prostaglandin, but at the peroxidase H2 synthetase site. And this therefore has some side effects of rash, fever, hepatotoxicity, leukopenia, and neutropenia. The advantages of this Tylenol therefore is cost and multiple doses from one vial. And disadvantages is a dosage concern because the dosage increases up to about 15 milligrams per kilogram per dose, which exceeds the usual analgesic dosage, and this therefore raises then concerns about liver safety, and there has also been no long-term data that has been shown for this as well. Some other therapies that are considered, but only for symptomatic use and has not been shown to close the PDA, is loop thiazide diuretics, which most commonly used would be furosemide. They decrease afterload and fluid in the pulmonary vasculature. Disadvantage would be the increase of PGE2, which is needed to close the ductus arteriosus, and ACE inhibitors like lisinopril or enalapril, which also decrease afterload. However, disadvantages again is that there is no long-term data, and they have renal failure and very serious adverse effects in preterm or low birth weight neonates. So monitoring closely is very important. Some non-farm management that is considered is also a fluid restriction. Fluid intake restriction was employed to close that PDA, but it's to reduce that pulmonary edema and reduce mechanical ventilator dependence. But it's also important to ensure that protein, glucose, calcium, and phosphorus are still at optimal doses. So about 130 to 140 milliliters per kilogram per day has been studied. And then as well, there has been some mixed practice and some argumentative discussion between NPO and NSAIDs and whether they would increase GI effects or not. And ventilator strategies as well, because they can decrease the workload, increase then cardiac output, which thereby would reduce the fluid output into the lungs. And surgical ligation is also another option as well. So in conclusion, there is a lot of questions that still need answers, but they are being studied. As I mentioned, when to treat, if to treat, and how long to treat. And they do vary based on the NICU and what the practice is. But it is still very important to understand the rationale for each treatment as pharmacists and as healthcare providers for the side effect profile and the dosing. And in general, just to ensure the proper management of PDA and also to ensure the best quality of care for our patients in the NICU. Thank you.